Welcome to Get the Facts, the program that provides you with information on government's policies and initiatives. I'm Theodore Henry. October is the month we raise awareness on breast cancer prevention, treatment, and feature incredible survival stories. It's a moment to reflect on the partnership that is necessary to fight this horrible disease. The Jamaica Cancer Society, JCS, is a non-profit organization dedicated to providing services for screening and supporting patients through treatment. Consultant General Surgeon Dr. Hugh Anthony Roberts is a partner of the Jamaica Cancer Society and now joins us to discuss more on breast cancer awareness. Welcome to the program, Dr. Roberts.
Thanks, Theo.
All right, let's jump right into it. It's scary. The thought of this is scary. Knowledge is a weapon, we hear. So give us
a good weapon.
A good weapon.
A good weapon.
So start us from the beginning. How is breast cancer detected, diagnosed? Yeah.
So it's usually a combination of clinical symptoms and signs, as well as radiological investigations, and then it's confirmed by a biopsy. So let's start from the beginning.
Right.
It's obviously the risk of breast cancer, as you probably know, is significantly more in women than it is in men. The classical features are that a woman presents with a painless lump, whether it's mobile, means it can move, or if it's actually stationary, but it's usually a painless lump. And that will lead them to, obviously, if they're seeing their GP or their gynecologist, to have investigations done, which usually comprises of a mammogram, as well as an ultrasound. If they're under the age of 30, it might just be an ultrasound.
Oh, okay.
But certainly over the age of 30, 35, they'll combine the two, because the problem with the mammogram, even though the technology has improved, is that the sensitivity, meaning how well it picks up problems, is less in younger persons. Even though most radiologists, once there's something there, they will still subject the patient to having a mammogram done.
Right. I want to blend something in that, but don't lose your track.
Sure.
You mentioned under 30, maybe that, over 30. So it's not a matter of age when it comes to screening.
Well, screening has to do with age, but you are asking me about how is it presented. So I was giving you the clinical scenario when they have something.
I still want you to go back to
right.
that.
So there are two ways if you want to bring screening into it. So screening is one way that we try to detect asymptomatic people.
Right.
But the classical way in which breast cancer presents is with a lump. There are other things that it can present, like a lump under the armpit, which is an axilla.
And that can happen at any time.
And that can happen as well.
It's not an age thing.
It's not an age thing.
Okay.
Even though the risk of breast cancer increases in age, especially over the age of 40.
Ah, okay.
But there are other factors, as we'll talk about with screening, where we're going to talk about the risk that patients have. So if you go back to screening, and I don't want to go all around the place, the first thing that we have to do is profile the person in terms of what their risk is. Their risk returns to other diseases that they may have had, in terms of other breast diseases, if they had radiotherapy, if they had a family history of breast cancer. Those are things that put persons at higher risk. But with regards to the two ways persons could present, the first one is they present with symptoms or a sign. And the most common one, or the most classical one, is a lump in the breast. And it's usually a painless lump.
Okay.
And then that will lead them to either be investigated by their surgeon, their gynecologist, or their GP. And that investigation usually is going to be a mammogram and an ultrasound.
Right.
That's going to be performed by a radiologist. And if there's a lesion there, chances are, well, the radiologist will score the lesion in terms of try to give you a predictive value of if it's cancerous versus non-cancerous. And that usually leads to a biopsy. Right. And the most common one that we use, not only in Jamaica and the region, but worldwide, is what we call a core needle biopsy. And that is then sent to the pathologist. It's usually under image guidance. So usually if the mass is detected on ultrasound, the radiologist will do an image-guided biopsy, core needle biopsy. And then you send that specimen to the lab. It takes about 2 to 4 weeks to get back a result, which would confirm that it's cancerous. And then we're going to go on from there.
Okay.
The converse, which you had mentioned, is screening,
Yes.
which is what we're trying to do or advocate for, especially during this month of October. We try to at least give people more knowledge about screening. So with breast cancer screening, doesn't pick up a precursor lesion. It actually picks up cancer at an early stage, right? And that is usually done, again, you profile the patients. The screening tool that we use is a mammogram. We advocate screening in the average population to start around age 40, and it should be done annually after that. But it's also combined with two other clinical stuff that we do. One is breast awareness, and that's being where we advocate for the person to be aware of how his or her breast feel, and we're going to specifically say her because we don't screen in men.
Right, right. Right?
And breast awareness is just simply like me asking you to draw everything in your bedroom. You can't. But if I go into your bedroom and I move a chair that's in the left corner to the right corner, as soon as you come in the room, you're going to know that something is different. Right? So we don't want women to actually examine their breasts constantly. But you know how your breasts feel like when you're lying down. You know how your breasts feel when you're taking a shower. There are even instances where it's actually the partner, the spouse, who actually tells you that there's something felt different.
So have a sense of what's
what
normal
feels.
and what has changed.
And the reason why we use the term breast awareness as opposed to self-breast examination is that the latter actually leads to paranoia. Right? I mean, if you keep on thinking something is wrong, eventually you're going to find something that's wrong, even though it may not be wrong.
Right.
And then that leads you to undergo anxiety. It leads you to obviously go through all of the other investigations that I mentioned, and you're going to come back with a negative result. So you wasted your time, you wasted your money, and you become extremely anxious.
Doc, we're gonna take a break right now. We're continuing this discussion on breast cancer. It's the month for it, and we're going to drill down into some more facts of this disease. Please stay with us.
It's time again for the JIS Heritage Poster Competition. Are you a secondary level student? Design a digitally or illustrated poster on the theme Echoes of Freedom, tracing Jamaica's path from colonialism to republic. Let's see your best design. Lots of prizes to be won. Visit jis.gov.jm for competition guidelines. Registration is now open and closes October 31. The JIS Heritage Poster Competition 2023. Enter today.
Welcome back to Get the Facts. We're continuing our discussion on breast cancer awareness, and now we will look at the treatment options and upcoming activities for October. And as context to all of that, Doc, what's the statistics in Jamaica?
So we feel about 8 to 12% of the female population is at risk for development of breast cancer in their lifetime.
Right.
As I said to you outside of this conversation, we have developed a breast cancer or breast oncology service at Kingston Public Hospital. Give a shout out to Dr. Jason Copeland as well. And we are actually gathering the stats. We've seen over 250 patients so far. So we're using that as a pool to get stats in terms of and other information as regards to breast cancer. But what I can tell you is, if you look worldwide, you always hear about screening should start at age 40, right? It's not true, actually. There are actually some countries, European countries, that start screening at 50. There was a time where America actually wanted to push their figures to 45, but we can't do that for a number of reasons. So even though we have an 8 to 12% lifetime risk amongst women, when you look at the actual stats of women who have breast cancer, in North America, their median age is around 59.
Right.
Our median age is about 6-7 years younger. You actually have about a third of the persons in Jamaica who have breast cancer actually develop it under the age of 50.
Oh.
And sadly, another 17% under the age of 40. So if we were to move that screening age up, you're losing 17% plus another probably 4, 5, 6%.
Right.
So the only reason why I think that we can't screen at an earlier age is because, as I told you earlier, that the mammogram is not as sensitive as you get younger. Right? It loses its sensitivity, and that's the primary screening tool, in addition to the clinical breast examination, which is done by a professional, and the women being aware of their breasts.
Right. I wanna touch on something here. We've been talking about screening and mammograms, and now we want to talk about treatment. But a question that always comes up is, can it be prevented?
It's unlike some cancers where you actually have precursor lesions, like for example with colon cancer. You're actually screening to find what we call benign polyps, adematous polyps.
You don't have that with breast cancer.
You don't have that. What we advocate is that women try to lead a healthy lifestyle. So no smoking, healthy diet, exercise. But we can't find an actual precursor lesion. What we do find are risk factors. So we divide risk factors into those that are modifiable and those that are unmodifiable.
Right.
Unfortunately, the unmodifiable risk factors are the ones that cause the highest risk. Being a female is the highest risk.
Okay.
As you increase in age, and sadly your ethnicity as well. And why I say sadly is because we are in a country that's primarily black population, and then you also have a high Indian population as well. And you find that those two races actually have a higher risk of breast cancer at an earlier age, and it's more aggressive compared to a Caucasian population. This is why we're trying to get our own stats and present our own data, which people have been doing, but we're trying to get more.
Understood, understood. So, something is detected. We've gotten the news of the worst. What's the treatment options?
So the treatment is what we call multidisciplinary because it takes different angles. You're talking to me as a surgeon because I'm supposed to be the primary person. And why I say supposed to be, because surgery is involved. You want to remove the mass, which means you could either remove the lump or remove the breast. The other surgeon who is usually involved outside of a breast or a general surgeon is a plastic surgeon. Because if anybody is going to have the breast removed, in the 21st century, they should also see a plastic surgeon with the possibility of reconstructive surgery.
Right.
Whether you use natural tissue or you use implants.
Life continues after the process.
The heme-oncologist who administers chemotherapeutic drugs, they have a primary role, and you find that their role with breast cancer is actually increasing every year because the drugs are becoming better. And almost every person who has breast cancer will fall into the category where they may need chemotherapy. What varies is the drugs that they get as well as how many cycles, meaning how many times they will get chemotherapy. And that's dependent on how advanced the tumor is, the cancer is, in terms of whether it's stage 1, which is early stage, versus something like stage 3.
Right.
And then it also depends on the grade of the tumor, which is how aggressive it is. So there are a lot of factors that determine what medication they get. And then the last person who is really involved in terms of the actual treatment is the radiotherapist. Their role is a little bit more limited, but still important, depending on whether the patients have advanced cancer or if they just remove the lump. Because if you do remove the lump, one of the things that we try to advocate is that you should receive radiotherapy afterwards. Because that will help to reduce the recurrence of breast cancer developing later on, because you still have the breast there.
Yes.
Right? There are other persons who are involved that must be mentioned, psychologists. You have local programs like Reach for Recovery, Jamaica Cancer Society, because once you've had cancer, and most women have 2 breasts, so you had cancer in one breast, it means now your other breast is affected. And then you also have the wider population in your family, so your first degree, your second degree relatives are also at increased risk compared to the average population.
You know, Doc, I'm listening to the treatment course that you're describing here. Getting sick sounds expensive. Are there any financial support options?
So let me say this disclaimer before I start. I do not have anything to disclose.
All right.
I think health insurance is probably the best way to go. When I look at the stats that came out from one health insurance company, they're reporting that fewer than 20% of the population has health insurance. And the third part is that I think persons should try to invest in themselves and have their own insurance. So a lot of persons get insurance secondary to their job, which is usually good insurance.
Right.
But if you worked in a job for 20 years and then you stop working, insurance is no longer present. And you're going to start working 20 years, means you're 20 years older.
Sure.
Insurance, at that time, if you decide to take out a personal insurance policy, it's going to be more expensive. So that's one. 2, I work privately, but more importantly, I work with the government. And as you know, the government has put things in place where healthcare is free.
Right.
It is resource limited, and the volume that we cater to is extremely large. As I said, we do have a breast clinic at KPH, and our limiting factor right now is operative time. So patients are getting seen quickly. A treatment plan is organized for them quickly. The heme-oncologist can administer drugs quickly for those who need it before surgery, but our limiting factor now is operative time, which we're asking for more. Clearly. In fact, this month, what we're doing is actually operating on Saturdays, our days off, to try to actually clear some of the backlog because it's Breast Cancer Month.
Gotcha. Well, thank you for the tips and the insight. We're in the last few seconds of this interview, and I'd like you to just speak directly to our audience. Give us a little insight into what's going to be happening for October in terms of
the Cancer
activities.
Society.
Yes.
Well, what we're doing here, I'm not the only person. You'll see other persons in the surgical field, oncology field, radiotherapy field, even persons who've experienced breast cancer just trying to spread the word about breast cancer. They make mammograms affordable. They actually help us with our clinic as well as best as they can.
Right.
I also think that what we need to recognize is even though we're talking about breast cancer in the month of October, this is something that goes on for the other 11 months. So even though you might talk about colon cancer in February or March, you might talk about prostate in September, these are things that need to be aware throughout the year.
Right, right.
And I just encourage all women, especially if you're over the age of 40, no matter even if you're 16, you haven't done it, to get your annual mammograms done and see your gynecologist or your GP or even your surgeon to have your clinical breast examination done. This can also be done at your profession where occupational nurse, health nurse.
Thank you so much, Dr. Robert. As you've heard the stats, you've gotten some advice in terms of financial assistance, you've learned about the treatment options, and one of the things I'd like to pull out is how important it is to take care of yourself and to prepare in the eventuality that such a thing may happen. So, this has been Get the Facts. Our guest was Consultant General Surgeon Dr. Hugh Anthony Roberts. I want to thank you for watching, and until next time, I'm Theodore Henry. Take good care.